Hello, very good morning to one and all. I am Dr. Laxmi Shrikhande, course convener, and I welcome you all for this A to Z IUI workshop. I would like to introduce you with our embryologist, Dr. Kersi Avari. He has come from Mumbai to cover the andrology part. I will be covering all the gynecology part starting from selection, stimulation, follicle monitoring, then the procedure, luteal phase support, and how to navigate through the ART Act level 1, how you all can start. So that part I will be covering, and he will be covering the interpretation of semen analysis, the sperm wash techniques, how you can start your IUI lab. So that andrology part, Dr. Kersi Avari will be covering. She is Dr. Rachna Singh. She is an embryologist with us. So we will first start with the lighting of Samay, and then immediately we will start with the workshop.
दीपज्योतिः परं ज्योतिः दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं दीपज्योतिर्नमोऽस्तु ते शुभं करोति कल्याणम् आरोग्यं सुखसम्पदः द्वेषबुद्धिर्विनाशाय आत्मजो
मेरा पहला presentation. Let's start with the selection because the patient selection matters. Before proceeding, you should know whom to take, whom to recruit for IUI. As we all know, IUI is the first line assisted reproductive technology for couples who are experiencing infertility, both primary and secondary. Infertility is a very crude word, so whenever we are documenting, we write subfertility, which gives them hope. So it is subfertility. IUI, it is minimally invasive, cost-effective alternative to IVF, particularly for those couples with mild male factor infertility, unexplained infertility, or ovulatory disorders. However, appropriate patient selection is crucial to optimize the IUI success rate. You should give them the realistic success rate, which is 10 to 20% per cycle, depending on the patient's age, ovarian reserve, and sperm parameters. So what are the prerequisites before you even recruit them for IUI? The minimum requirements are that you have to document ovulation in that cycle. I know you are doing IUI for ovulatory disorders. So you are using stimulation protocols. So by that stimulation protocols, there should be ovulation, patency of at least one fallopian tube. You have to inseminate with an adequate number of motile sperm. Dr. Kersi will elaborate in great detail. And there has to be absence of documented or suspected cervical, intrauterine, or pelvic infection. So let us first understand what are the factors which affect the IUI success rate. And when we are talking of factors, the first and foremost thing which comes in our mind is age of the woman. It is very, very important. As the age advances, there is decline in the oocyte quality, and this is well documented. There are n number of papers where they have correlated females' age with decline oocyte quality. Even more effective treatment options, like when we are doing IVF, ICSI, they also cannot completely overcome the negative impact of age. Because if oocyte quality is poor, our embryologists are handicapped because we will get poor quality embryos. So we cannot enhance the oocyte quality even when we are doing IVF, ICSI. Many studies have documented a significant drop in the success rate beyond the age of 40 years, with reported live births as low as 1.4% when you are talking of IUI. Put together, for women who are over 35 years of age, your controlled ovarian hyperstimulation combined with IUI as a treatment option needs careful consideration when you are considering the woman's age. Above 40, it's really a poor treatment option. If she is young, yes, she has got a good success rate as compared to the older woman. The second parameters we affect your IUI success rate is semen parameters. So there are various sensitive indicators with respect to different sperm parameters which determine the prognosis of IUI, and sometimes whether you should go ahead with IUI or not. Though there is no overall consensus for the cutoff, it's not like black and white, but most studies have determined impaired success rate in following scenarios: where processed total motile sperm count is less than 10 million, normal sperm morphology is less than 4%, inseminating motile count is less than 1 million, and rapid progressive motile post-wash is less than 25%. The third factor which affects your success is etiology. For what reason she has come to you and you are advising IUI. Indication for which IUI is done is one of the most crucial factors for predicting the success rate as well as from counseling standpoint, because I said you have to give realistic success rate. And a large Indian retrospective has assessed this very well. This is the large Indian retrospective study where they have done the IUI success rate depending on the etiology. So you can see if you are doing it for ovulatory dysfunction, success rate is the highest, that is 21.2%. For tubal factor, 11.5. For endocrinological factors, it is 13.4. If you are doing for unexplained infertility, it is 11.8. For male factor, if it's mild OAT, then it is 14.7. Combined, sometimes it is not male or female. Both male and female contribute to the infertility, and in that case, the success rate given in this study is 15.1. So you can see the overall success rate is 14.1%. Cervical factor is the most rewarding indication when it comes to the IUI success rate, because it gives you as high as 51%, because you are bypassing that cervical factor. If the etiology is endometriosis, then for minimal endometriosis, the success rate is 21%, and for mild endometriosis, it is 18.9. Success rates have been found to be lower with pathological uterotubal function or surgical resection performed, even for minimal or mild endometriosis. Now coming to the unexplained infertility. Here it is written CC because this is an old study by ASRM, but whether you are combining it with letrozole IUI, which is usually the first line treatment for unexplained infertility because of its good clinical pregnancy rate, relatively low rate of multiple gestations, oral route of intake, lack of need for intense monitoring, and low cost. For women who do not conceive with your oral ovulations and IUI, ASRM suggests IVF as the next step rather than gonadotropin therapy. IVF results in the highest per cycle pregnancy rate in the shortest time interval. However, there are limitations of IVF which includes high cost, high rates of multiple gestation unless and until you are transferring single embryo, which in India, we IVF specialists, we are hesitant to do single embryo transfer because your success rate gets lower down if you are transferring minimum. So we prefer to transfer 2 embryos. How many IUI cycle can you do for unexplained infertility before you proceed to IVF? The current recommendations are 4 cycles of IUI. Does body mass index matter? Because nowadays we are getting more and more patients who are on the obese side. So I am quoting the studies here. This was the study published in 2020, where they have summarized that this was a retrospective study, and the findings of this retrospective study do not support an association between BMI and live birth rate among patients who are undergoing treatment with IUI. So you can go ahead. The obesity per se does not give you lower success rate. However, there were certain limitations of this study. Nevertheless, you should know that obesity and pregnancy, they have strong association with adverse maternal and neonatal outcome. So you have to counsel them ki our success rate is not affected, but you might have increased maternal and neonatal adverse outcome. So you have to counsel them accordingly. So these were all the factors which affect your IUI success rate. Now let us have a look at indications for IUI. Because in IUI, you can totally avoid the coitus. It is particularly useful in those couples who are having severe forms of sexual dysfunction, like severe vaginismus or ejaculatory dysfunction, or discordant couples in terms of sexually transmitted infections. For cervical or mild male factor infertility, IUI allows sperm to bypass the potentially hostile cervical factors, thus increasing the number of sperms that gain access to the uterine cavity and in turn to the oocyte. For women who are doing ovulation induction, including those with unexplained infertility or minimal or mild endometriosis, pregnancy rates are thought to be higher when IUI is used as an adjunctive procedure instead of timed natural intercourse. So when you are counseling them in your OPD, suggest IUI over timed intercourse. In these couples, IUI is often used as an intermediate level and cost-effective intervention prior to going for IVF. So in short, I have summarized the indications for IUI. In male factors, it is mainly the ejaculatory dysfunction when he is having retrograde ejaculation, hypospadias, impotence. There is infrequent intercourse with these high-tech IT couples, and if you have to proceed with the donor insemination. For female, cervical factor, mild endometriosis, unexplained infertility, severe vaginismus, and discordant couples. What are the indications for donor inseminations? It is azoospermia, severe male factor infertility, a single woman, and same-sex female couple who wants to conceive. They can come to you for donor insemination as per ART Act. Whenever you are doing or counseling them for donor insemination, there are certain legal and ethical concerns that you have to go strictly with the ART Act. There are consent forms available on the website. You have to use only cryopreserved sperms. Even before ART Act, we used to teach that don't use fresh semen sample for IUI insemination. It has to be a cryopreserved sperm procured from a reliable, registered ART bank. They give you 2 cards. You have to keep 1 card in your record, and in case of donor insemination, you have to preserve the records for 18 years till the child becomes major. Are there any contraindications for IUI? Yes, if it is cervical atresia, there is cervicitis. Moderate to severe endometriosis, we don't prefer IUI. When there is bilateral tubal blockage and when there is severe OATS, oligoasthenoteratospermia. Now you know the indications, you know the prognosis. Now you have to start with the counseling, because counseling makes lot of difference. As I said, success rate is on the higher side if you consider 18 to 20%. So you have to counsel them that it's an ongoing procedure. Minimum, we would like to go through 3 to 4 consecutive IUI cycles. Remember, the word consecutive is very, very important. If you don't counsel them properly, they will do 1 IUI with you. If it fails, they will change the doctor. So when counseling, I tell them that changing of doctor is not going to help them, because that doctor will start from the scratch. So they should stick to you and give you time to do 3 to 4 consecutive IUI cycles. Then you have to counsel them why you are advising them IUI, what is the procedure, what is the success rate, how many cycles. I have already told you, minimum 4. The cost of the IUI cycle in your center, the complications of the cycle, and in India, the bed rest is the biggest question. They are not concerned about the procedure and the cost. Everyone is concerned about the how many days I have to take the bed rest, which I will tell you in detail when I am telling you about the IUI procedure. And whether you are doing IUI by husband semen or donor semen, ART Act has really simplified or made our life very easy, as it has given us the consent forms both in Hindi and English. So even our Maharashtrian couples, they understand the Hindi. So you have to fill the form according to the ART level 1. Now don't refer to the ICMR consent forms. Once ART Act has come, we now no more fill those ICMR consent forms. Now start, after counseling, it comes the pre-treatment workup. And any pre-treatment workup starts with the history. So you have to start with the detailed menstrual history. Rather, if you take menstrual history in great detail, you can figure it out whether she is having ovulatory cycle or anovulatory cycle. Because if her cycles are regular, she is ovulating. Detailed history, obstetric history, history of previous treatment, medical history, whether currently she is on any medication, family history. Don't forget to take coital history in great detail. To our surprise, we still get cases of unconsummated marriage. And they feel that they have consummated and they are not conceiving. So do take this history properly, whether the marriage is consummated, wife is having vaginismus, the husband is having ejaculatory dysfunction, or with these IT couples, their coital history, it is very, very infrequent intercourse which they are doing. And at the end, don't forget to ask the couple, do you want to tell something more? And they can sometime come out with the history which we have not figured it out. After history taking, it is the examination. Don't forget to look at the BMI, general examination. Yes, it is very, very important. After that, proceed to the per speculum and per vaginal examination, which has become obsolete. But remember, at least once before the start of treatment, you should do the per speculum examination for knowing any cervicitis, vaginitis, cervical erosion. You might see any cervical polyp. So at least do per speculum examination, and after that only proceed with your transvaginal sonography. Don't put the probe directly without doing PS and PV examination, because you all should do antral follicular count by yourself. Call her on day 2, day 3. So to look for AFC and simultaneously look for any uterine or ovarian pathology. Then comes ordering of the blood reports. These are the mandatory things: CBC, blood group RH typing. AMH we are doing for each and every couple who is coming to us for fertility, whatever the guidelines are telling you. because guidelines are there just to guide you. You don't have to abide them blindly. Prolactin and TSH, these are mandatory. Because I am practicing in Vidarbha area where sickle and thalassemia is on a higher side, so we do HPLC also for our patients. Rest all the hormonal profile, because I also see many patients who has done each and every hormone which is there in your record. It is not needed, even that is not needed for IVF patients also. These are more than enough to guide you how to go about your stimulation protocols. Now, whether you should do HSG mandatorily before proceeding with IUI, this is the guideline when you should go ahead and look for the tubal status. So if the clinical history is suggesting tubal pathology, that is, she is giving you history of any PID, history of any previous DNC, history of any previous appendicitis surgery for appendix, or for any matter, history of any previous surgery in the pelvic region. Women who are more than 35 years of age, irrespective of the history of tubal pathology, you can go ahead and do the HSG, because her fertility is already on the decline and you don't want to waste the precious time. The guidelines are telling you that if there is no risk factors for tubal disease, you can postpone the HSG and you can go ahead with your ovulatory cycles. But in clinical practice, it makes more sense to first assess for the tubal status, document that her tubes are patent, and then go ahead for IUI. Rather than wasting her 3 to 4 cycles of IUI, then doing HSG, then you are telling the couple that now look, your tubes are blocked, that is why you are not conceived. And the patient will say, what? You should have done that earlier. So again, whatever guidelines are telling you, in your clinical practice, do HSG before proceeding for IUI. Document the tubal status, and even if only one tube is patent, you can go ahead with IUI, but do tell her that success rate has declined by 50%. So if it was 20% with bilateral patent tubes, now it is 10% as she has got only one patent tube. Pre-treatment workup, don't forget to do semen analysis, because it is always the couple counseling. Don't counsel them separately. The wife is coming, then husband is coming, and he is busy, she is busy. No. Tell them to come together. These are the semen parameters before you proceed for IUI. The semen volume 1.5 to 5 ml, count more than 10 million, motility more than 40%, and morphology more than 4%. So from patient selection presentation, the key takeaways are IUI remains a valuable fertility treatment when it is applied to carefully selected patients. It is most effective in young women with good ovarian reserve, and that is why you are doing age, AMH and AFC. These three things are more than enough to tell you about the ovarian reserve in that particular woman. You don't need to do any further test.